Dear colleagues, I'm Christoph Diener from the Faculty of Medicine at the University of Duisburg-Essen in Germany. And in this video, I would like to cover 6 publications on stroke, which were published in October 2024. Let me start with systemic thrombolysis. We have now 2 thrombolytic agents available. One is the well-known alteplase, and newly approved for the treatment of stroke is tenecteplase. And the ATTEST-2 study in the United Kingdom, published in Lancet Neurology, compared tenecteplase 0.25 milligram per kilogram body weight as a bolus with alteplase 0.9 milligram per kilogram body weight as an infusion over 60 minutes in the 4.5-hour time window in 1,777 patients with ischemic stroke. There was no significant difference between the 2 thrombolytics for the primary endpoint, modified ranking after 90 days. There was also no difference with respect to mortality, intracranial bleeding, and extracranial bleeding. Now, we finally have 11 randomized control trials which compared tenecteplase and alteplase in acute ischemic stroke. And a meta-analysis of these randomized trials was published in Neurology. The analysis included 3,700 patients with tenecteplase and 3,700 patients treated with alteplase. For the primary endpoint, excellent functional outcome defined as modified ranking 0 to 1 after 90 days, there was a significant benefit for tenecteplase, relative risk 1.05, but the absolute difference was very small with 3%. There was no difference in mortality and bleeding complications. And in conclusion, I think both substances are great. They are effective. Tenecteplase is most probably the drug which should be used in people who have to transfer it from a primary stroke center to a dedicated stroke center which provides thrombectomy. Otherwise, I think it's a choice of the physician which thrombolytic agent to use. A highly debated topic is mobile stroke units. These stroke units have a CT scanner and laboratory on board, and this makes it possible to perform thrombolysis on the way to the hospital. A retrospective observational study collected data between 2018 and 2023. 19,400 patients with acute stroke, of whom 1,237, which is 6.4%, were treated in a mobile stroke unit, published in JAMA Neurology. The modified ranking scale at the time of discharge was better in patients treated with a mobile stroke unit, but the absolute benefit was only 0.03 points on the modified ranking scale. And the question still is this cost effective? And can we really do this at times when you have a dramatic shortage of physicians anyway in the hospital and of nursing staff? Now, oral anticoagulation, as you know, is usually considered a contraindication for systemic thrombolysis. And idarucizumab, the monoclonal antibody, was developed to reverse the biological activity of the bigetran and then allow systemic thrombolysis. A recent publication in Neurology analyzed 13 cohort studies with 553 stroke patients on the bigetran who received idarucizumab prior to systemic thrombolysis. And the rate of intracranial hemorrhage was 4%. And this means it's obviously possible to perform thrombolysis when the activity of the bigetran is neutralized by idarucizumab. Unfortunately, until today, we have no data whether this can also be done with andexanet alpha in people who are treated with factor Xa inhibitor, like, for example, apixaban, rivaroxaban, or edoxaban. Now, my next topic is ESUS, embolic stroke of undetermined source. And we have 4 randomized large trials and 3 smaller trials, which compared antiplatelet therapy with DOACs in patients with ESUS. And a group in Neurology published a meta-analysis of 7 randomized control studies with altogether 14,800 patients with ESUS. And the comparison between antiplatelet therapy and anticoagulants showed no difference for recurrent ischemic stroke and also not for major subgroups. And this means that people with ESUS should receive antiplatelet therapy, most probably aspirin. And my final topic is the optimal time to start anticoagulation in people with atrial fibrillation who suffered an ischemic stroke. The Optimus study published in Lancet randomized 3,650 patients who were anticoagulated with the DOACs either early, which means less than 4 days, or delayed between 7 and 14 days. And there was no difference in the primary endpoint, which was a recurrent ischemic stroke, intracranial hemorrhage, or systemic embolism at 90 days. The conclusion is most probably we can initiate anticoagulation in people with ischemic stroke and atrial fibrillation in most cases within the first 4 days. Dear colleagues, October 2024 was an exciting month for the stroke field, and I presented 6 new studies, and they have impact, I think, on the management of patients with ischemic stroke. I am Christoph Diener from the medical faculty of the University Duisburg-Essen. Thank you very much for listening and watching.